Welcome to MedMastery's Cardiology Digest, where we unleash expert insights and discuss the latest scientific findings in the field of cardiology and medicine. In today's episode, we'll dive into the findings of 3 recent papers covered in top cardiology journals. These include a study showing whether or not popular home blood pressure devices sold online are validated for accuracy, a study showing which type of ambulatory blood pressure best predicts mortality, and a study that evaluated whether apixaban or warfarin was associated with more thromboembolic events in patients with an on-X mechanical aortic valve. As always, we've provided you with links to each of these papers in the show notes. Be sure to tune in weekly for updates and new insights. And don't forget to subscribe now to stay updated on the latest in the field of cardiology. Peter, I'm really interested in the information you're about to share about home blood pressure monitors. These are widely used, so I know how important it is that patients get this right.
Thanks, Nora. This next study was really interesting to me too. It's great that patients can keep an eye on their blood pressure at home, but we need to make sure they have the info they need to be successful. This study was published in JAMA and is titled Availability, Cost, and Consumer Ratings of Popular Non-Validated versus Validated Blood Pressure Measuring Devices Sold Online in 10 Countries. Researchers used data from Amazon to identify the best-selling devices sold online in 10 countries and then determined which devices have been validated as accurate. The findings revealed that approximately 80% of both arm and wrist devices were not validated, with some differences across the 10 countries studied. Interestingly, validated devices had a median price tag that was roughly twice as high as that of non-validated devices. Validated devices had a median cost of $67, while non-validated devices had a median cost of $32. This study highlights the importance of ensuring accuracy when monitoring blood pressure at home. It's a good idea to ask patients to occasionally bring their home devices to the office so we can double-check their accuracy compared to our office devices. We should also advise patients to choose validated devices, which can be found using online directories such as validatebp.org and stridebp.org. Speaking of blood pressure, Nora, do we have any resources for listeners who want to become great at diagnosing and treating it?
We sure do, Peter. Be sure to check out MedMastery's Hypertension Mini Course. It breaks down the most recent hypertension guidelines and tells you when to use or not to use the top 4 first-line agents, which will help you to quickly and effectively make treatment decisions for the majority of your patients. Now, Peter, I know you've got a really interesting study coming up next, also relating to blood pressure, and I can't wait to hear about it.
Thanks, Nora. My study was published in The Lancet in May of 2023. The study, conducted by Staplin and colleagues, is an observational cohort study that explores the relationship between clinic and ambulatory blood pressure and mortality. Now, you may be asking yourself, what's the difference between clinic and ambulatory blood pressure? Well, clinic blood pressure is typically taken at a doctor's office and only reflects your blood pressure at that moment. On the other hand, ambulatory blood pressure is taken throughout the day and night, giving a more accurate picture of your blood pressure over an extended period of time. In this study, researchers analyzed data from a Spanish blood pressure registry of 59,000 patients who met European guideline indications for ambulatory blood pressure monitoring. The patients were followed for an average of 10 years. Here are 4 key findings of the study. First, systolic blood pressure was generally associated more strongly with all-cause and cardiovascular-related mortality than diastolic blood pressure. Second, 24-hour ambulatory systolic blood pressure was almost 5 times more informative for the risk of death than clinic blood pressure. And nighttime ambulatory blood pressure was about 6 times more informative for the risk of death than clinic blood pressure. Third, compared to daytime ambulatory systolic blood pressure, nighttime ambulatory systolic blood pressure was nearly 2 times more informative for the risk of death. Fourth, patients with masked hypertension on 24-hour ambulatory but not clinic measurement were at excess risk for all-cause mortality, whereas those with white coat hypertension were not. So what does this mean for us? Well, it confirms the prognostic value of 24-hour ambulatory blood pressure measurement, and particularly overnight measurement, in a large but selected patient population. However, limited availability, variable insurance coverage, and variable acceptability to patients can be barriers to the use of ambulatory monitoring in the U.S. Overall, while this study highlights the benefits of 24-hour ambulatory blood pressure monitoring, more research is needed to determine if it would improve clinical outcomes more than a combination of office measurements and self-measurements at home. That wraps up our discussion of study number 2. Now, Nora's about to tell us which anticoagulant caused more thromboembolic events in patients with mechanical heart valves.
I sure am, Peter. This one is really interesting. It's from the New England Journal of Medicine and is titled Apixaban or Warfarin in Patients with an On-X Mechanical Aortic Valve. This manufacturer-funded, multi-center randomized trial evaluated the use of these two drugs in patients who had on-X mechanical aortic valves. The study administered either standard dose warfarin or apixaban for at least 3 months after surgery. The warfarin dose targeted an international normalized ratio, INR, of 2 to 3. The apixaban dose was 5 milligrams twice daily. Also, most participants, 84%, received low-dose aspirin throughout the trial. During a median follow-up of about 13 months, it was observed that the rate of thromboembolic events was 4.2% per patient year with apixaban, compared to just 0.3% per patient year in the warfarin group. With this concerning finding, the study was halted prematurely after enrolling 863 participants as a result of the higher thromboembolic events in patients taking apixaban. It's pertinent to note that for a median 73% of the time, warfarin was able to maintain a therapeutic INR. Also, both groups received aspirin. Those two facts make the difference between apixaban and warfarin even more worrying. Despite the benefits of oral anticoagulants like apixaban in patients with atrial fibrillation, this study adds to others that have shown direct oral anticoagulants should not be prescribed for patients with mechanical heart valves. Before I pass the mic to you, Peter, I just want to remind everyone, if you find our summaries helpful, make sure you subscribe so you can easily stay up to date with all of these new developments in cardiology. All right, over to you, Peter.
Thanks, Nora. Now I want to ask you, our listeners, if you're looking to become the best clinician you can possibly be. I bet you are, so look no further than MedMastery. Our platform is designed to teach you the most important clinical skills, so you can solve over 90% of patient problems without the help of a more senior colleague. We're not just tooting our own horn either. Our award-winning courses have won numerous teaching awards and are even highly recommended by the British Medical Association. Plus, all of our courses are CME accredited, so you can be sure you're getting the most up-to-date information. But don't just take our word for it. We've taught hundreds of thousands of clinicians worldwide, and 21% of our subscribers say that we've already helped them save lives. So if you're ready to become a great clinician too, head on over to medmastery.com and check out our courses. A free trial is waiting for you. With our help, you can gain the knowledge and skills you need to provide the best possible care for your patients. Well, this has been fun, but it's time to wrap things up. Next week, we'll have more important studies to tell everyone about. But in the meantime, thanks for listening to today's episode. Don't forget to subscribe, and we'll see you guys at the next one.